So good evening, everybody. Thank you for inviting us onto this webinar tonight, Dawn, on behalf of myself and the rest of the SMART team in Swansea. So my name is Honorary Hutchison, and I'm a consultant physiotherapist from Swansea Bay Health Board. I have a special interest in foot and ankle injuries, and particularly the Achilles tendon, having done a PhD on Achilles tendinopathies and being part of the team that developed the SMART protocol. So tonight I've been asked to talk about the functional approach to the management of Achilles ruptures. And this is based on our protocol that we developed in Swansea in 2008, known as the SMART protocol. So the protocol was developed by many members of the multidisciplinary team, including nurses, radiologists, consultant orthopedic surgeons, and other physiotherapists, as well as academics. So we're very fortunate tonight to have an expert panel on this call. So I will ask the panel to contribute during the presentation, but also you're all welcome to ask them questions at the end. I'd like to thank them all as well for giving their time tonight. So I'll just introduce you to the panel. So we've got our consultant radiologist, who is Dr. Rodri Evans. He's also an associate professor. We've got our orthopedic consultant surgeon, who's a foot and ankle surgeon, as well as a pediatric surgeon, and our clinical director currently, that's Mr. Paul Williams. He's also an expert in Achilles ruptures because he's ruptured his himself. We've also got Professor David Beard, who is a professor at Oxford University and works with us on just a small part-time basis as a ESP physiotherapist. And unfortunately for him, he's also currently a patient of ours. We've got our staff nurse, Lindsay Gwillam, who will be able to help and answer any questions around the early immobilization side of the protocol, particularly the cast immobilization. And we've got an ex-professional footballer, Christian O'Leary, who played football for Swansea City as well as Wales, and now he is a professional coach with the Swansea City under-23s team. He is also an ex-patient of ours. So why do we call it the SMART protocol? So SMART, the S stands for Swansea, because that's the city with the hospital that we work from. And M is for the hospital that we work for, which is Morriston Hospital. The ART is then for Achilles tendon rupture treatment. So all details of this protocol you can find in the paper that we published in 2015 in the Journal of Bone and Joint Surgery. So because there's a varied audience on this call tonight, I'm just going to go through a little bit of the background in relation to Achilles ruptures first, and then we'll move on to the protocol. So the Achilles tendon is the thickest and strongest tendon in the body. Despite this, it can sometimes rupture. The tendon attaches our calf muscles to our heel bone and allows us to put our foot in the downward direction or plantar flexion. It also enables us to balance, walk, run, jump, and hop and tiptoe. So the Achilles tendon can rupture. It can rupture in the body of the tendon, around the ankle area, or where the tendon joins into the lower soleus muscle at what we call the musculotendinous junction. Achilles tendon ruptures are common, as you can see on our panel tonight. Already two of our experts have ruptures theirs, but it affects approximately 10,000 people in the UK per year. It affects most ruptures occur in the sporting population aged between 30 and 55. This is known as the weekend warrior injury, and it also affects 20% is in the elderly population. This is normally from antibiotic or steroid-induced ruptures. Whilst an Achilles rupture is not limb-threatening or life-threatening, it can be quite disabling for patients, particularly for them to return to their sports or hobbies. It can also be career-threatening for the professional sports person, as well as very disabling for the elderly, particularly in relation to their balance. So what causes the tendon to rupture is not clear, but one thought is the forces which are placed through the tendon, particularly when it's in a stretched position, for example, during the push-off or deceleration, can cause the tendon to rupture. It often occurs as well in the patient that's not fully conditioned, hence, and it can rupture them with little force, hence why it's called the rupture of a weekend warrior. So someone who hasn't done activity for a while and returns to that sport. It's also at increased risk if it's degenerative or if the patient has been on certain medications, for example, prior quinolone antibiotic treatments or been on steroids. So the patients often describe themselves hearing or feeling a pop or a snap or feeling as if they were shot in the back of the leg. But you have to watch you're not caught out, because sometimes patients don't actually feel anything at all. Interestingly, most patients report that the tendon rupture causes them minimal pain. But they complain of difficulty with walking, running, going up on their tiptoes and balancing. Clinically, when we look at the tendon, we carry out some tests. This is Mattel's test, where we get the patients to bend their knees to 90 degrees. On the left-hand side, where the Achilles is intact on this patient, you can see the resting position of the foot as a plantar flex position. On the ruptured side, where the tendon complex is no longer holding the foot up, the foot drops down into a dorsiflex position. Another test called the squeeze test, also known as Simmons test or Thompson's test after the people that reported the test, is where you squeeze the calf muscle. On the good side, you can see the foot moves, and then on the ruptured side, you see there's no movement of the foot at all. That's seen as a positive test on the rupture side when you squeeze it and there's no movement of the foot, because people often mix up a positive and a negative with these. I also recommend when you do this test that you look at both sides, because sometimes you'll find that the ruptured side, if it's a partial tear, will still move slightly, but it'll be significantly reduced to the other side. Another test that we use is to palpate down the posterior aspect of the tendon.
No, it's not true, please, Chair.
Feeling for a step in the tendon. Sometimes you have to be careful with this test that you're not caught out, because if the posterior aspect of the tendon is intact, then you can think that the tendon is intact. Another test that I haven't shown on you, which a lot of clinicians often do, is to get the patient to push their foot up into a plantar flex position against resistance. Again, you need to be careful with that test, because the patients can use the long toe flexors to plantar flex the ankle. So you've got to watch that they're not cheating, because obviously if the tendon is ruptured, the gastrocsoleus complex isn't going to work. So the tests I've just shown do have quite a high accuracy to them. I've probably seen over 1,000 ruptures, but sometimes it's difficult for me to know actually whether the tendon is ruptured or not. And we have to remember that these are in the top 10 orthopedic missed conditions, so they're not always easy to pick up, and we need to go on and sometimes get an ultrasound scan. So we're talking about tonight acute ruptures. So those are ruptures which occur that we see within 2 weeks. So we want our patients really to attend after they've ruptured to the hospital fairly quickly, because a delayed presentation can greatly affect the patient's outcome. So if a patient continues to walk on the rupture, then you find the tendon ends will pull further and further apart, which can make it difficult then for us to treat these patients. They'll either then need to go on to have complex surgery, which is often FHL surgery, which maybe Mr. Williams can talk about a little bit later if we get time. So the aims of our management is that we want the tendon to heal. We want it to heal at the correct length and tension, and we want the patient to return to a maximum push-off with limited complications. So we don't want our patients to end up with a wound problem, which can happen if they have an operation. We don't want them to have a nerve injury, a functional deficit, or a re-rupture. So our treatment options are, we can either manage a patient with or without an operation for this injury. It's controversial whether a patient will be managed with or without an operation, and this is still the case. This is because historically it was reported that if a patient was managed without an operation, there was a high chance of a re-rupture, but fewer complications, and vice versa if you were managed with surgery. So the complications with surgery are the infection and potential wound breakdown and nerve injury. So historically, conservative treatment was reserved for patients with comorbidities or for the lower activity demand patient. But this was really until the functional approach came about, which obviously we're going to talk about it later. So this was because it was seen using this approach that the tendon could heal well at a good length and tension, with the patient returning to good strength, with limited risk of complications and a low risk of a re-rupture. So when we're talking about the functional approach, we're talking about the period of immobilization. So historically, patients, whether they're managed with or without an operation, were managed first of all in a cast for the first few weeks with the foot in the downward position, that they would have to be non-weight bearing in this cast. They're managed for 3 weeks in this position. And then the foot was brought up into a mid-equinus position. So midway, again, they'd be non-weight bearing for 3 weeks. So that's 6 weeks now of non-weight bearing. And then the final 3 weeks would be in a neutral position or a walking position where they could weight bear. So with the functional approach, we're able to get the patients to start exercising the ankle and the gastroc complex very early on, and we get them to weight bear very early on. And obviously I'm going to go into the details of this as we go along. So studies, both animal studies and human studies, have found that this mechanical load into the tendon helps increase the tensile strength of the scar tissue. Obviously, this has to be done carefully, because if you overload the tissue, then we would re-rupture the tendon. So there was 2 papers which came out, which really were game changers for people using the functional approach. There was this paper from Canada, where they compared the functional accelerated approach to patients having operations, and found there was no clinical difference between the groups. And then this paper from Wallace in Northern Ireland, who managed 945 patients conservatively through a functional approach, and reported a re-rupture rate of just 2.8%. So that's a very low re-rupture rate for conservatively managed patients. So our protocol we wrote in 2008, when it was born really because unfortunately Mr. Williams, who's on the call, had ruptured his Achilles tendon. So our protocol involves the functional approach, which I will go through, but we base whether our patients would be managed with or without an operation on the ultrasound scan findings. And all our patients do at the very end then a supervised physiotherapy rehab process. So I'm going to go through all 3 parts of our protocol. So initially, the ultrasound scan. We've got Dr. Rodri Evans on the call here, so he can add in to any parts of this as well. I'll ask him at the end of this section if he wants to add anything. So Rodri helped us to design this form. So what the radiologist does for us is they fill out this form to give us details about the rupture. So they don't just tell us whether the tendon is ruptured or not. They provide us with this further information, which helps us to decide whether the patient will have an operation or not. And if they're not going to have an operation, what's the best position for the foot to be immobilized in. So they let us know if it's a complete or a partial tear, where the tendon is ruptured, if it's in the body of the tendon, or where at the musculotendinous junction, where soleus joins into the tendon. They shade on this diagram for us how much of the tendon is ruptured, if it is a partial rupture, and they let us know their level of confidence with the scan, because the later the patient presents, the more difficult the scan is to interpret for the radiologist. And then finally, I'll just show you this in larger view. They let us know the gap size in the varying positions of the foot being held in equinus. So this is at 20 to 30 degrees. So we want to know the gap size at this point, because that's the position, the maximum position of equinus you can get with 2 different boots. And then in full plantar flexion, because that's the position that we can get with a cast. And then if we can't close the gap with full plantar flexion, does bend in the knee close the gap anymore by taking some pressure off the gastrocnemius? So once we get those details, and they also let us know if there's any herniation of any tissue between the tendon ends, particularly cages fractured. Once we've got that information, then it will help us decide on the management of the patient. So this is just quite a good video to show what we're talking about with the gap size. So there's the rupture, and as we bring the foot up into a plantar flex position, we're looking on the scan how well the tendon ends come together. So now this is a scan showing this. So you can see the gap here between the tendon ends, this black area in the middle of the scan. And then as the patient's foot is being brought passively up into a plantar flex position or a ballerina position, You can see with this patient that the tendon ends come together nicely. So surgeon doesn't need to go in and pull those tendon ends back together and put a stitch in it. So for us, this patient would be managed non-operatively. So ultrasound is the gold standard investigation for us because of its dynamic component, because we want to move the foot. And there's no indication for us to use an MRI for an acute rupture. So I don't know, Rodri, would you like to add anything about the scanning in?
No, I think just I think you've covered all the important points. I think the one thing to emphasize is, as you said, is that it is much easier to scan these patients early. The difficulty we have is that once patients are 2-3 weeks down the line, it's really difficult to actually differentiate between hematoma, organized hematoma within the gap or whatever like that. And then often the patient has quite a stiff ankle and it's difficult to get them to move, whatever. The preference for us is to scan early. It's much easier. Thanks.
Okay, thanks, Rodri. Okay, so once we've got those details from the radiologist, we then make the decision of whether the patient would be managed with or without the operation. So this is our protocol. So we've said that if the gap is more than 1 centimetre, the rupture is in the body of the tendon, and as a general guideline, it will obviously depend on how physiologically well the patient is. The patient is 55 or less and has a complete rupture, then that cohort of patients would be managed with an operation, but they would need to have all 4 of those. All other patients, so if the gap's larger, is less than 1 centimetre, is at the musculotendinous junction, or the patient is 55 or more, partial tear, and they'd be managed non-operatively. So the reason for the age side of that is and Paul can just add in on this in a second, is because I believe the older the patient, the higher risk it is of complications with wound and skin breakdown. So one of the questions we get asked a lot is, why did we pick 1 centimetre as our gap size? In all honesty, it was quite arbitrary, the reason why we picked it at the time. We know that sometimes on the scans, the gap can be filled with hematoma. And there is few studies in this area, to be honest with you. They're quite poor in quality and quantity, but these studies do give us some idea around the gap. But this is probably an area that does need more research. So this is a study from the Cambridge group, and they found that if the gap is larger than a centimetre, then the power or there's a larger torque deficit for these patients. However, interestingly, there's no difference in the questionnaire scores, their ATRS scores. The Leicester group, they found that the location of the rupture was more important than actually the gap size. And then more recently, the Reading group, who scanned 131 patients, they reported that the patient score on the HRS score, so this is a questionnaire the patient fills out, gets lower the bigger the gap becomes. So they recommend that the high activity demand patients should have an operation if the gap is 5 millimetres or more. So that's our information around scanning. So the next part of our protocol then is the functional protocol, part of our protocol. So for this, this is how our patients are immobilized. So if our patients have an operation, they're placed from surgery into a back slab, or actually Mr. Williams puts them into a dorsal slab, so a slab across the front of the foot. Then if they manage conservatively, they put in an appropriate Quinus cast. So that's a position where the foot is put down so that the tendon ends meet. So the best position where the tendon ends meet. So we will put all our patients in the cast initially, even if the tendon ends meet at 30 degrees, which is the position that a boot can give you. And this is because we know the patients can't take the cast off during the inflammatory phase, the first 2 weeks. So it'll stabilize the hematoma. It also reinforces the severity of the injury to the patients, because remember that the patients don't get a lot of pain with this injury. Also, there's a lot of information for the patients to take on in the initial consultation. So it means that they kept safe for those first 2 weeks. And over the last 9 years, we've actually started to get our patients to weight bear in this cast to see if it would reduce the DVT rate. If our patients have poor mobility, however, going into that Aquinas cast can be really quite difficult for them, and we may place the patients then into a air cast boot with 3 wedges. But if you do that, you just need to be aware of this paper that's been published by the Liverpool group by Phil Ellison and Linda Mason, where they looked at the position of the foot in the air cast boot, and you can see that most of the equinus comes from the midfoot rather than from the ankle joint or the talocrural joint. So you can question really whether you are shortening the tendon or bringing the tendon ends together in this position. However, this boot is a lot easier to use and can prevent a social admission. And we find for an elderly patient with a low activity demand that the patients do well with this. So most of our patients, over 95%, will go into the cast. So this is the cast. So the foot is put in the best position where the tendon ends meet. And then we put a heel wedge on the bottom of it so the patients can weight bear on the cast. So this is one of our patients walking on the cast. So they are placed into this cast for 2 weeks. They can weight bear from day 1. Any questions around the cast, you can ask Lindsay or a nurse who's on the call later on. And then after 2 weeks, we take the patients out of the cast and we place them into this boot, which is called a Vecoped boot. It's especially designed for Achilles ruptures. So this boot is, it's got a hinge mechanism in the back. At week 2, we lock it at 30 degrees, and then the patient remains in the boot for a total of 8 weeks. We unlock the boot at various intervals during those 8 weeks so that we can unlock the hinge in the back. So as the patient is walking, the tendon can glide to stop it getting stuck to the surrounding scar and causing scar tissue. The scar tissue getting stuck to the surrounding tissues. Again, we encourage our patients to progress to full weight bearing in the boot. Each time they come to clinic for a change, for the foot to be moved up, we ask them to bring their crutches, but pretty quickly then we want them to move to full weight bearing. If your patient has got any underlying back or hip pain, then we recommend that they get an even up shoe so that their back or hip pain problem isn't exacerbated. So our immobilization protocol, this is detailed in our paper, but for those of you who haven't seen our paper, you can see that for the first 2 weeks, the patient is put in the cast, either non-weight bearing if they managed operatively, or the non-weight weight bearing equinus walking cast, and then they all go then into the walking boot. So 30 degrees for 2 weeks, and then, for 3 weeks, and then 15 to 30 degrees, 5 to 7 weeks. We unlock the boot 7 to 9 weeks, and then fully unlock it 9 to 10 weeks. We remove the boot then at week 10. We give the patient a heel wedge to go in their shoe, and we leave them with the boot to wear in vulnerable environments over the next 6 weeks. So that's anything that involves alcohol or lots of steps, stairs, and people, for example, watching sports in stadiums or concerts. We get the patients to start early exercises at 5 weeks into the protocol, which is with using TheraBand, so resisted exercises for both soleus and gastrocnemius, so with the knee bent and with the knee straight. For the elite athletes who've got the daily physiotherapy, the physiotherapists sometimes start the complex treatment on these patients during the immobilization phase. This is a muscular facilitator. But obviously in the NHS, we don't tend to get the time to treat the patients. And then our final part of this protocol is our supervised physiotherapy rehabilitation. So the main rehab problems we find when the patients come out of the boots is that the decreased range of motion, so the tendon is tight, tends to be tighter for the surgically managed patients to the non-operatively managed patients, decreased power, decreased balance and proprioception, and decreased plyometric function. So obviously our aims are to reverse each of these during the rehab program. So rehabilitation wise, our protocol is divided into 4 phases. The first 2 phases are for all patients, and then phases 3 and 4 are for the high activity demand patients. So patients exit the protocol if they lower activity demand after phase 2. So in phase 1, and if we've got time at the end, I'll show you examples of these exercises. we aim to get the patients to single leg balance, double leg heel raise, walk without crutches, and get the tendon length equal left and right. Once the tendon length is equal left and right, we stop the patients doing the range of motion exercises because we don't want to over lengthen the tendon. In phase 2, we try and get the patients to single leg heel raise with hand support. We do double leg plyometric exercises if appropriate for the patient, and start some dynamic proprioceptive work. And then in stage 3, we start running, hopping, and then stage 4 is return to sport work and actually returning to sport. So we don't let our patients run until 6 months post-injury, no hopping till 8 months post-injury or hill running, and then return to most competitive sports 8 months post-injury. The elite athletes who've got access to this high-level sophisticated equipment can start running a little bit earlier. So this is an Ultra-G treadmill. So the athlete goes into a pair of shorts which seals around them, and it reduces the amount of gravity then going through the legs. So you can do this up to 10% of the body weight going through the legs. So you can start running in 4 months of fracture just but obviously most NHS departments have not got access to this sort of equipment. So when the patient is going to return to sport, the tests that we do on our patients is we look at their heel raise, comparing the height that they raise on the injured leg and the non-injured leg. And we want them to be able to lift single leg heel raise to at least 3/4 of the height of the other side. We look at their vertical jump height, single leg. So they do 3 hops on the good leg, and then on the other leg, you can get the patient to put a little bit of chalk on their hand and mark the wall, and then you can compare one leg to the other. Again, you're looking for them to be able to hop to about 3/4 of the height of the other side. If the athlete is an elite athlete, then they will have all these measures pre-season. So obviously you're trying to get the athlete back to what they were before they injured their Achilles. Most NHS patients were not going to have that data. This is the agility T test. So where you put cones on the floor in a T position, and that you time this test and you actually have the ability to stop, start and change direction. And it's a time test. And then we look at the crossover hop test, comparing the good leg to the bad leg. Again, we're looking for them to be able to travel at least 3/4 of the distance of the other side. You can use the outcome scores, which are the questionnaires that we use. The ATRS score is the validated questionnaire for Achilles rupture. So we look at this with our patients at 4 months, 6 months, and 9 months. They scores out of 100. The closer to 100 the patient is, the better they are doing. So you can see if they're progressing from their own subjective point of view. So what's the results of our protocol? You can see we introduced our protocol in 2008 when Mr. Williams ruptured his Achilles tendon. This bar chart shows in blue the number of patients who were then being managed without an operation, and in red, the patients who were being managed surgically. As time went on, more of our consultants became confident in our protocol. By 2013, most patients then were being referred to us in the Achilles clinic. So at that point, you can see there's a dramatic decrease in the number of patients that were being operated on, and it's just 1 patient per year approximately that is operated on now. So our results show that of 547 acute ruptures, just 6 have re-ruptured, so we've got a 1.1% re-rupture rate. So this is the lowest re-rupture rate that's been reported in the literature, hence why people are very interested in our protocol. And then the secondary outcome measure is at 9 months. You can see these are scores out of 100. The closer to 100 the patient is, the better. Remember though, the sedentary patients can't score for some of these. They can lose up to 30 points because they're not able to run, jump and hop anyway. Just out of interest for you, if you compare our patients which are managed with and without an operation at 9 months, although the numbers are a lot lower for surgically managed patients, you can see that the scores are actually slightly higher for the conservatively managed patients. So we often are asked, well, what about the elite athlete or the high activity demand athlete? Because some surgeons still get a bit nervous about managing these patients conservatively, even if they fulfill the criteria of our protocol. So all I can do for this is to show you some examples of patients. So this is Megan. She's our youngest patient to rupture. She ruptured her left-hand side. And this was her returning to badminton. And I'll just fast forward some of this for you. Oops, sorry. Okay, and then this was one of our patients who was a ballerina. She initially did dancing professionally, and now she's a ballerina teacher. So she's ruptured her right Achilles. And this is her at 8-9 months post-rupture. You can see she's got a little bit of loss of muscle, or she's got muscle wasting a bit on the right-hand side. But functionally, she's doing very well. So she was managed conservatively, and she's a rupture at the musculotendinous junction, complete tear. And then this is a rugby player, so he's a professional rugby player. This is him at the end of the protocol, hopping on his good leg. And then on his injured leg, again, he's managed non-operatively, and he returned back to professional rugby, no problem. So we're often asked about the cost implications of this protocol, because other centres throughout the UK which have set this up often have to put in a business plan to set up these clinics. So all the details of this are in our paper. And these are cost avoidances that we found by putting the protocol in place and avoiding operations, and despite increasing the number of ultrasound scans for the patients. So it caused a cost avoidance back in 2013 of nearly £92,000. So future developments for our protocol is we're currently working with a computer company called ProMap. So we are looking at getting all our outcome data put on an electronic platform. And then this can be used then by other centres throughout the UK that use our protocol. So I believe at the moment that there's almost 100 centres throughout the UK that's using the SMART protocol. We've had lots of physios come to our centre, and we've taught them sort of within our clinics how to set up the protocol. And then if other centres are interested in using this once it's up and running, then obviously we could amalgamate our data at a national and an international level, which would be great. We're also about to launch an app called Pop to Hop the Smart Way. So this is an app that can be used by patients following removal of the boot. It will take the patients through stage 1 and 2 exercises for the most sedentary patient, and then all the way through to 3 and 4 for the high activity demand patients. So it gives the patients an exercise program of what to do every day. It's also an educational app to tell them about their injury. And this was really driven by the patients, the development of this app. And our patients have been heavily involved in the development of this, including Christian O'Leary, who is on the call now. I'll just quickly show you some examples of the exercises. So very early on, this is a range of motion exercise. Simple exercises we get our patients to do: stretching of soleus, stretching of gastrocnemius. So these are stage 1 exercises, just weight transfer when you've come out of the boot. Simple weight transfer, and then moving on to a little bit more, lifting the foot a bit higher, just so the patient builds up some confidence. All these are on our app. And then balance exercises, dynamic balance exercises, walking forward and backwards or across the line. We encourage the patients initially to walk with an elbow crutch so that they get the push-off phase of gait. So it's better they walk normally with crutches than to be hobbling without them. double leg heel raises, tiptoe walking with crutches so they can use the assistance of the hands. Progressing on to double leg heel raises with holes. And don't forget to do soleus strengthening exercises, so with the knee bent. Further balance exercises. Some early plyometric work, so you can take up some of the weight through the hands. And then these are later stage exercises. I've only picked out a few. We've got sort of 200 plus exercises on the app. So these are proprioception exercises combined with balance exercises. Some running drills, forward and backwards, high knees, striding. Change of direction work. For our rugby players, more running down on the floor. The eccentric lowering, we don't introduce until 6 months due to the risk of re-rupturing the tendon, especially when you're pushing up from a dorsiflex position. So don't mix this up with the eccentric for tendinopathy patients. And then this is obviously for a patient who was very fit before. Okay, so just to summarize, our SMART protocol has 3 main areas to it. So all our patients receive an ultrasound scan so that it'll help us determine how the patient is best managed with or without an operation. And if they manage without an operation, what's the best position for the foot to be held in? They all then, whether they manage surgically or conservatively, managed via a functional rehabilitation protocol, which I forgot to say is managed by the physiotherapists rather than the orthopedic surgeons in our fracture clinic. And then all our patients go through a supervised physiotherapy rehabilitation protocol. So all the details of this are in our paper. And any questions to myself or the panel. But before we do, I was wondering if Christian as a patient could give us some feedback of his experience of going through this. Just to remind you, so Christian is an ex-professional footballer, played for Swansea City in Wales, and now he's a professional football coach, coaching the under-23s in Swansea City. So Christian, you can give a little bit of the story around what happened.
I was obviously retired a long time ago, as you can see, but I was unfortunate enough to be one of what Honorary calls the weekend warriors, and thought I could still do what I used to do. And I ruptured it playing football with my friends on an evening, just a friendly kickabout. But it's exactly as Honorary said. I felt as if someone had kicked me from behind. I knew that there was no one there, and with my background, I pretty much knew what I'd done straight away. So it was, thanks to Honorary and Paul and the team at Morriston. I was very surprised, to be honest, with the way that the treatment went, because I was expecting to have surgery, having sort of had many surgical interventions throughout my career. I thought that was the natural way of doing it, but it certainly was. It was a journey. It's just a long time, but the work they do is fantastic, and it was. Obviously, it takes away the risks of the linked to the surgery itself. But the way it was the pathway through was very, very simple and intriguing for myself, having not my background of what I would have had the physio daily. With the capabilities of the boots, you sort of knew exactly where you were every couple of weeks. It was right. Okay, after 3 weeks, I know I'm going to get into a different boot. Then we're going to open it up a little bit, we're going to start moving, and the treatment was fantastic.
Okay, and you've returned now back to everything you need to, Chris. So
yeah, a little bit slower, but yeah.
Okay, and then I just wonder if Paul now, Mr. Williams, our orthopedic surgeon, if he could go through a little bit of his experience and maybe talk a little bit around the surgery. This is especially because Mr. Williams himself had an operation, so he was managed quite differently to Christian.
Yeah, hi everyone. I first saw the Vacaped boot as a consultant, thinking that looks like something I might try on a patient if we get somebody with a rupture, not knowing it would be me. About 10 days later, so I had a traumatic rupture. A bit like Chris said, my expectation was surgery, because as a surgeon in training, and I've been a consultant about 8 years at that stage, it was very much the thought that we should be operating on patients with Achilles tendons. I had a tendon body injury. By the time I came back from skiing where I injured it, there was a reasonable sized gap anyway. Dr. Audrey Evans very kindly scanned me. I remember his words, "It's only an Achilles tendon rupture," is what he said to me, as if to say, just man up and get on with it. But for me, it was a major injury, as it is for the majority of us. And so I had surgery with one of my colleagues, and fortunately that went very well. I didn't have any of the complications. And as a result of that, we used the Vacaped boot to rehab me. And we began to understand more and more that it was the functional rehabilitation that was likely to be giving the improvement rather than the surgery itself. And that's really how it was born. And you can see from the screen when Anne-Marie showed, there was a little bit of reluctance, shall we say, amongst my colleagues to accept that surgery maybe wasn't the answer for this injury. But they're all converts now. They're all converts in our department. That's not necessarily the case throughout the world, and it is a bit horses for courses. So if there's any specific questions about the surgical side of it, I'm happy to answer it. But I do paediatric orthopedics. The physios in paediatric orthopedics try and keep the kids away from me, and now the adult physios are doing the same because of this. So although I'm a surgeon, I'm very encouraged not to operate on the majority of patients, and I suspect Professor Beard would be happy about that as well.
Yeah, thanks, Mr. Williams. I was just wondering actually if Professor Beard, Dave Beard, who was my PhD supervisor, actually a very academic guy, he's a professor at Oxford University, when fortunately ruptured his Achilles in lockdown, whether he would give his sort of story behind this, especially with his professor head on with us managing the patients this way.
So first of all, thank you very much, great presentation. A lesson in research integrity. So being part of the original SMART research team, it makes you realize that you have to get your research right, because you never know where you're going to need it yourself. So that was the first learning for me. I think this whole process for me, and a lot of it has been covered already, there's a couple of salient points. One is that it's a real lesson particularly for the therapists out there, that it is so critical to get the patient to listen to instruction. This is a process which you have to listen to instruction. The whole process is, it's sort of smattered with empirical evidence, but there's an awful lot of it which is sort of considered rationale and practice which has gone on for a long time and built on. And that instruction, as you go through it, is really important. It's very easy not to listen to that and to sort of waver off it, but it's really critical for that. A second point I would make is that the first period for me was really important, and it's a horrible period. If any of you have been in a cast, it's really uncomfortable, and I could have ripped it off. I went in twice. I thought mine was wrong and uncomfortable, and I think Mr. Williams incorrectly or politically incorrectly called me the princess, but it's a very uncomfortable thing to be in, and you have to appreciate that with the patient as well, but you have to adhere to it. That for me was probably the most difficult period. And then the last thing I would say is that as a patient, you have to have patience. And it's very easy, especially if you've got some knowledge as well, which most people in this area do. You want to race ahead, you want to do things which you perhaps shouldn't do. And it goes back to the instruction, but the patience is a really critical part to it. You have to hold firm and believe in what you're being told. But I've had a very good experience altogether. And again, back to playing five-a-side football now at my age, which is great. And not having an operation, which I think is probably the best way to go. Well, it was for me especially.
Okay, thank you everybody. I think we'll move on to the questions now, Dawn, if that's okay, please.